prescriptions over 50 and also over 90 also saw very significantly higher chances for opioid overdoses and opioid addiction. So we wanted to, one thing the CDC made clear in their guidelines and that we wanted to do with our research is limit any high prescription opioid doses. Links to illicit use, similarly on the right, the chart on the right, many people, it's not just, as you can see, prescription opioid rises, illicit use rises, and we think it's mainly because first, non-medical use. So people, when they receive their prescription opioids, might not be educated on how they should store them, and their children or friends get into them, and then they get addicted, and this leads to illicit use. Also, and this has been scientifically proven that, a study on heroin users found that 80% began with non-medical use. So when you have more prescription opioids out, there's a higher chance of non-medical use or even just addiction for the patient who's actually receiving them. Prescription opioids still haven't been scientifically proven to treat chronic pain. This seems surprising, but because they are really good at treating pain, but what we see is when we use long-term opioid use, we have long-term opioid prescribing, is that often patients begin to develop more pain, and it's this effect where they become more pain sensitive. And this doesn't happen with everyone, but it's just a tolerance kind of effect. And many people, when they actually start to taper off opioids, their pain actually decreases because they don't have that hypersensitivity to pain anymore. So that's why we want to keep at low doses. And honestly, if it's not working or if they're getting more pain from opioids, we want to limit long-term opioid treatment and find alternative methods. And then I think the final point is, again, non-medical use, which is huge for mainly like adolescents who often get into non-medical use of opioids. Maybe some opioids have been left over, but that's like the main mode that adolescents become addicted to opioids and can lead to illicit use. But it's obviously not just adolescents. Adults also may have non-medical use and then lead to illicit use in the future. So this is why we want to limit opioid prescribing and have safe guidelines, safe prescribing and adherence to opioid guidelines. And that's what we've been trying to do with our research, which I'll explain in a few slides. Next slide. Okay, so this is our conceptual model. So if anyone is not familiar with research, basically this is how is our map or our guide, like our thought process as to why we're doing this intervention, what we see as issues, how we can target those issues. So as you can see in the left, we have antecedent factors, so factors that could lead to you getting opioids, being prescribed long-term opioids. So acute pain, you can get a short-term opioid treatment, which ends up being a long-term opioid treatment and having some sort of addiction or a high dose. Age, so as you get older, actually younger populations are more likely to get addicted if you are prescribed at a younger age. Sorry about that. Chronic pain. So if you are of chronic pain, you're obviously more likely to have long-term opioid treatment, and history of substance use disorder. That is something that could lead to potential for abuse. And then other things that are moderating these factors that are causing a lot of prescription opioids. There's poor alternative pain management options, and also a lack of time for providers to focus on pain management. So often people come in for like an annual or follow-up appointment, have pain, but also have, a bunch of chronic diseases to take care of. So, pain isn't a central focus at that appointment. So you just re-up the prescription, don't really talk about it, don't talk about how it's controlled. And it can often lead to missing diagnosis of misuse, or even the possibility of just tapering a dose or getting people off opioids. and then other mediating mechanisms that can lead to potential use. So inconsistent substance use disorder screening. So we catch someone with a substance use disorder that's on opioids, we can get them help. Urine toxicology screenings. These are basically just to see if there's any concurrent drug use, which is a sign of maybe a substance use disorder. So let's say you're prescribed opioids, and there's also, they take a urine toxicology and they see that you've been using cocaine as well. And that could be a sign of potential for abuse. Not updating controlled substance treatment agreements is something that providers use to kind of give patients understanding of what they have to go through to get prescription opioids. So that should ideally be urine toxicology screenings and substance use disorder screenings regularly. But if you're not going over that with the patient, they might not remember. And also the doctor, if they aren't signing this, then they might not do consistent substance use disorder screenings. Lack of prescription for naloxone. So I think there's just a stigma of naloxone, and patients and their family may not want it because they're like, oh, my family member would never overdose, or we're not at risk of overdose. I just think that it's always good to have with a prescription of naloxone if you're receiving opioids. So that may be a potential way to prevent overdoses. And insufficient patient education. So just preventing non-medical use mainly. And also, so like things like storage or disposal of extra medications that we should be educating patients on, as well as like different side effects and stuff like that. So through that, we tried to develop this intervention that would help implement evidence-based guidelines for opioid prescriptions in our clinic, and address some of these factors that we saw as the causal theory for abuse of prescription opioids and inevitably opioid overdose. So as far as some key takeaways, I haven't listed it, Miranda, you could just, so we saw that there's a lack of adherence to evidence-based guidelines for providers, not necessarily their fault, as I'll get into, need for patient education, and it became our primary aim to implement this evidence-based approach to chronic pain. Next slide. So these are the evidence-based guidelines, and as you can see, it's just a handful for providers. So you're trying to, so the first thing, it kind of goes like as the arrows point, things that you would go through as a provider if you're treating someone with pain. So the first appointment, you would try to maximize alternative pain management. And these, it can be like PT, NSAIDs, such as like aspirin and stuff like that. Things that would be less harmful, even like nerve blockers like gabapentin, things that aren't as addictive and haven't seen such negative effects. And then establish a care plan, which is basically just saying with the patient, okay, what's your pain level right now? If this is acceptable, if it gets to this point, what we're going to do. If it gets better, what are we going to do? Just creating an actual care plan, so it's not just, we're not just going in the dark on this, and trying to actually take care of the patient and have a plan set in place to manage their pain, try to quantify it and stuff like that. So once their pain, you can't control it with alternative pain management, the CDC wants you to assess and discuss risks and benefits. So is it going to benefit this person to be on opioids for long-term more than their pain is preventing them to do daily activities? And then you would start on immediate release opioids, just because, so this is short-term acting, stuff that just like you might get for deal with like short-term pain during the day. And then in between those, you would take aspirin and stuff like that to help mediate the pain in between doses. Just because long-term opioids are these extended release are more likely to lead to opioid overdose, just because it's just consistently, it seems like there's a higher dose in your bloodstream at all times because it's an extended release. And then the next, like I talked about before, with avoiding high doses, because that can lead to opioid addiction. And then also they mentioned acute pain. So you want to limit long-term prescriptions with acute pain. So if someone is in the hospital for a minor surgery, don't send them home with 21 days of opioids. Send them home with 3 to 7 days of opioids, so that there's no room to get addicted from those that type of prescription opioid treatment. And then immediately, as soon as you prescribe an opioid for the first time, reevaluate in 1 to 4 weeks. Is your pain better? Is your pain worse? Do you think you have too high of a dose? Can we maybe limit that? And then let's say you're taking 2 immediate release a day and with aspirin in between, can we take 1 and then 1 at night and then your aspirin during the day? And then you're continuing to reassess. So hopefully every 3 months after that. And we use things such as urine drug tests and substance use disorder screenings to ensure, and it says at least annually, but you ideally do it 3 months to ensure that there's no concurrent drug use or that there's no substance use disorder, underlying substance use disorder. One thing that I haven't mentioned is avoiding opioid prescribing of the benzodiazepines, which is basically another it's a benzodiazepines are a depressant. So it's been found that, and with opioids also having some depressant qualities, mixing them with benzodiazepines can lead to a higher likelihood of overdose. And then finally, if you find someone with substance use disorder or potential substance use disorder, we should make sure that they get treatment, whether it be an outpatient clinic or inpatient clinic. So as far as why isn't this happening already? And prescription opioids are going down. That's something I should mention, but not at the rate we would like. And we still see people overdosing on prescription opioids, non-medical use, and way too high prescription rates. So why, even though we have this evidence-based guidelines that I just laid out, why are they not being implemented? And we need to figure that out before we create an intervention that address these implementation barriers. So the things we found are capacity for organizational change. So many places, whether it be a large primary care center or a small primary care center or a privately owned center, a clinic, there seems to be that some places just continue to treat the way they always have, which it goes into clinical inertia, which is what it's called when a physician ignores new evidence and continues to treat based on how they've always treated, just because it's how they've always done it. And then we've seen other things like level awareness. So maybe these guidelines came out, but no one educated them on it, which is something that you could do with continuing medical education. And then as well as resources. So time constraints and incentives. So physicians are often incentivized to try to get as many patients as possible, which leads to time constraints. We just can't discuss these important I'll go through all these important evidence-based guidelines to meet all your patients. You rather just be treating the chronic diseases or acute diseases that they came in for, rather than the underlying substance use disorders and stuff like that. So that's just something that we decided to create our own appointment with. So as far as pain management goes, instead of just running through a follow-up, we decided, what if we just had a pain management appointment, because that would limit the time constraints and the resource constraints that providers saw with just follow-up appointments dealing with pain management. Because usually what happens when a follow-up appointment, someone comes in, they're complaining about pulmonary issues or heart issues, but they're not addressing the pain issues. And if they are, it's usually just I'm in more pain, and instead of really discussing it or going through trying to quantify the pain, you may just up the dose due to time constraints. So we we were trying to work to address that. Okay, next slide. So this is our study design, and if you're not familiar with research, I'll explain everything going on here. So it's a quasi-experimental design, which means that there's two groups. I was working at the Hurdle Elmwood Internal Medicine Clinic, where we are going to implement the intervention, which I will get into. And then there was a control group, the Buffalo General Primary Care Center, where there is also patients receiving long-term treatment for opioids, but we were not going to put the intervention in there. Just to see how the intervention had effect over time. We were going to do a difference in difference analysis, which really just seeing how outcomes changed over time with the two clinics. Did we see better outcomes for the patients at the Hurdle Elmwood Internal Medicine Clinic compared to the Buffalo General Clinic? That's basically a difference in difference analysis. I don't have to go in much deeper than that. And all you really need to know is that the intervention was happening at the Hurdle Elmwood Clinic, and we're just using Buffalo General Clinic just to compare to see if we're actually making a difference. So as far as the data we're trying to look at, we're using a medical records review. So there's certain outcomes that we wanted to see. We wanted to see the doses, the average dose of opioids that patients were on going down. We wanted to see more people being screened for substance use disorders, more people receiving urine toxicology screenings, and we wanted to ensure that patients were, or actually physicians were following all these guidelines, so we could look at medical records and see exactly what they did. When I show you the data later, it'll make more sense. And then we did a monthly data collection, and which got paused due to COVID. Like I said, we did difference analysis. So as far as the intervention, so like I said, we created our own appointment, and we called it the chronic pain management appointment, or CPM appointment, or comprehensive pain management appointment, and or CPM appointment for short. And that was our practice level intervention. So it's a 1 hour appointment, just focused solely on pain, so that we can ensure that we're not prescribing too many opioids, or that we're actually addressing the pain and not just, giving them medication to help alleviate pain without really looking for substance use disorders or trying alternative methods. So this is just a brief overview of the visit on the right. So the patient was checked in, the nurse did some screenings, and we'll go through all this in a little bit. And this is kind of a redesigned workflow. It's an hour-long appointment dedicated solely to pain. And as far as provider level interventions, we provided education and reference sheets. So we use a lot of CDC references that I'll show in later slides. And patient education, we're providing them with education on how to store and dispose, how the side effects you could possibly have. And we also provided like Narcan training for family members if they're there, and a few in early implementation of this intervention, a few people actually did, family members actually did receive Narcan training, which is great. Some with patients that actually had previous opioid overdoses. Next slide. So this is the pocket guide. This is what, when I was talking about provider education, this is what we gave. We laminated a bunch of these for our providers to use. And it basically goes through all those guidelines that I mentioned earlier when I was talking about the CDC guidelines, and as you can see, it's pretty similar. And it just kind of goes through exactly what a provider should do. So instead of just giving them one education section, we have this guideline, this pocket guide at all times available to them, so that they know exactly what they're going in and doing when they go into a chronic pain management appointment. And it goes through simple stuff like, calculating doses and ensuring that we're getting below 50 MME and, just basic guidelines for opioid prescribing. The next is just the nurse's checklist. So you can see kind of what the appointment was set up like. So we're ensuring that they're checking for controlled substance treatment agreements. Have they had urine tox? If not, they're going to get one today. Stuff like screening. So PHQ-9 is for depression. And it's something we like to screen for with patients who are receiving opioids, just because depression can be linked to opioid overdose. And then opioid abuse as well. And then PEGs are pain enjoyment general activity scale, which is something we use to quantify pain. So on a scale, it's just 3 questions on a scale from 0 to 10. What's your pain at today, or in the past week or 2 weeks? And then how much of pain limited your enjoyment, and how much has it limited your general activities, both on a scale of 0 to 10. And DAS is also a screening we use for substance use disorders and drug abuse. Additionally, nurses will be providing patient education materials and
Froze a little bit, sorry.
Okay. The next slide was going to be the provider's checklist. Yeah. And they would, after the nurse did all the screenings, look at them. Okay, so this person has depression, or their pains are not controlled, or they may have underlying substance use disorder. And from that, they would also look at their medications. So are they also prescribed benzodiazepines? What is their morphine equivalency of their medications? And try to determine, okay, should we have to decrease the dose? They're at a safe dose, maybe we should stay the same. Or maybe they're depressed and have positive substance use disorder screenings. Maybe we should talk about prescribing Narcan, or even getting them into treatment. Providers are ensured to look at pain history, use the pocket guide to do a medication discussion, as well as create a care plan. And then they also have a Narcan discussion, and we ideally, the patient brings their family member with them so that we can get a Narcan training. And we had free Narcan kits there. So we would write a prescription, but it wasn't like there was any cost associated with it. So that blocked any insurance barriers or anything like that. As far as how we can improve we wanted to make sure that we weren't causing any rifts in our traditional workflow. And that's something you'll see with a lot of workplace interventions, is that you introduce this new appointment, it's great, it's working well, but it takes away from other aspects of patient care. So we created this survey just based off a CDC pamphlet that helps create survey questions, and to see what our providers are struggling with. Do they need more education? What the education do they need? Are they comfortable with the visit? Are patients responding to the visit? Do you think that's helping patients? Is it disrupting workflow in any way? So this is, we got a few providers to finish this, but again, with everything being kind of shut down, we weren't able to finish this. But ideally, what's going to happen is providers fill this out, and we can continue to kind of tinker with our workflow, see what works better, and improve on our project. This is the survey we were going to give to our patients. And as you can see, it includes the PEG, so the general activity enjoyment pain scale, the first 3 questions. It also helps the provider identify where the pain is. And then it gives the patient a say in okay, the last question is, how satisfied are you with your pain management treatment? So it gives them a say in okay, are you liking what we are doing now with this chronic pain management appointment? Is it improving your pain? Is it affecting other things like your anxiety and stuff like that? Is there side effects to your medication that you had to bring up? Just things that may have been missed in the appointment. We want to ensure that our patients are happy with the appointment and that their pain is improving. Because if their pain isn't improving, then it's not a successful intervention. Okay, next slide. And as far as patient education, this is the pamphlet that we gave, as well as we have a Narcan pamphlet. I didn't include it in the slides, but just a brief thing that goes over side effects, risks of misuse, other options that you could maybe talk to your doctor about, and if you're prescribed, what you can do to help reduce misuse. So like returning excess prescriptions, storing them in a secure place. So it's just a basic education that we had our nurses give to patients just to ensure that if just they were storing their opioids properly, they knew what they were getting into with opioid prescriptions, and they knew how to dispose of them if they didn't want them anymore or weren't using them fully, the prescriptions. Okay, next slide. For time reasons, this is more of like a research-based thing. I'll just go through it quickly, I guess. But this is just limitations to our study. So one limitation we found was trying to schedule patients. So as I mentioned, there's workflow issues, and especially with a 1 hour appointment, just adding another appointment to a patient's list is difficult, especially if they may not want to pay the copay, or it's difficult for them to go to an hour appointment with busy schedules, or if the just providers are fully stocked and they can't fit another hour appointment into their schedule. So that was one thing we've been trying to find a way out, and maybe shorten the appointment to like a 30-minute appointment. And we're looking into that. Lack of provider education. So a lot of providers are aware of the guidelines, but may not know, we're never trained on how to really create a care plan for pain. And that is why we're trying to create targeted education for our providers. Workflow issues, and that's just basic issues that may have caused like a decrease in patient. Just because we're focusing on pain, we may miss other chronic conditions. So we're just monitoring that, and then randomizing sample groups is just something that we can't do with 2 clinics. So this is just our baseline data that we took. And as you can see, we didn't have many people on high dose opioids. That's the 50 to 90 MME. But what you should notice is that urine toxicology for 12 months is really poor. So we wouldn't be able to tell if there was concurrent drug use, as well as our substance use disorder screening was at 17%. And that's also really poor. Ideally, we want 100% from that. And some things that we're doing well is, I guess, like depression screening. And it's just, I think because the PHQ is so readily used, and like mental health is such a priority today, or in some primary care clinics, especially this primary care clinic, we prioritize mental health. So we have relevant screenings available in our EMR to quickly and rapidly screen for depression. So it just makes it relatively easy. So as far as, so this was 2 months in, some preliminary data, and it's compared to our baseline data. So 100% of the patients that came in for these appointments had substance use disorder, a substance agreement signed. So they knew that they would be getting urine toxicology screenings. They were educated on storage and disposal. They knew that they would be getting urine tox screenings. And then 100% got substance use disorder screenings. And then 100% had the PEG, which is the scale to help quantify pain and ability to do daily activities. As far as our patients on high dose opioids, which I said there was only a few of them, I think there was 6. For the ones that came in for appointments in the first 2 months of our intervention, 50% received naloxone in the first month, and 2 out of 3 received naloxone in the second month, and then 100% of them were tapered. So it's a small sample size, but it's good to see that these high dose patients are either receiving naloxone or reducing their dose. So here's just the conclusions. There's early signs of success, small sample size again. There's an increased emphasis on pain management, which is good. But at the same time, we don't want them prescribing more opioids. We just want to focus on pain management, but also following guidelines, helping find alternative methods. And then as far as lessons learned, we need input. So some of the data was missing, as you saw. There was a larger chart for the baseline data as compared to the follow-up data. And that's just because there's some lag in in providers getting in the data to the EMR, because some things had to be scanned in, other things just like notes weren't finished. So that's something we needed to focus on so we can continuously track and monitor and improve this. And as far as pain management education, we're going to create education sessions for the providers at the clinic. And translational research like this, which is basically taking evidence-based guidelines and implementing them in a real-world setting, is essential. And that's something we found just because it can easily improve quality of care without disrupting workflow. As far as public health and community assistance, it's working to alleviate opioid misuse. It's quality insurance. So if you go in to get your pain managed, you're hoping that they're not going to be, they're hoping you're using the most evidence-based guidelines to treat your pain and not just blindly going, trying to treat with medications that may or may not work. Impacts on future research. So we're hoping that workflows like this will happen more often in the future, so that all the evidence-based guidelines are being or taken up more rapidly. So something like this, where you can easily adjust the workflows, they're just Microsoft Word documents that providers have to check off, makes it relatively easy to create these kinds of translational research. So just for community's sake, things you can do. I think it's great that you're coming here, educating yourself, also educating. You should work to educate others, and I think that's mainly on understanding what opioid misuse looks like. So resources like Johns Hopkins or the CDC, you could easily just look on their websites, and they will give you some symptoms of opioid misuse, what it looks like, how to address it, how to get someone help. Especially in Buffalo area, we're doing pretty well on getting people into treatment. More and more providers are getting licensed to prescribe Suboxone, so that you don't have to go into inpatient treatment. Help to monitor prescription opioid misuse or opioid use. And by this, I mean, if you have someone that's prescribed opioids, go to the appointment with them, ask if you can get a prescription for naloxone. Ask them how they store their opioids. Are they locked away? Are they in a safe spot where no one will find them? Are they disposing of excess opioids? Just things that you can do for someone if you know someone who's prescribed opioids. Even if it's acute pain, someone has surgery, make sure that they're not receiving excessively long opioid prescriptions. And Narcan training, so Erie County has great community Narcan training. I just highly recommend going to one, just in case you ever see opioid overdose. You'll be able to help maybe before EMS arrives, and you could save a life. And that's all.
Right, so I'm going to stop sharing my screen. So thank you, Cody, so much. That was extremely informative and educational. So thank you for sharing all of that research, that you worked with some colleagues to do. So now I'm going to open it up to the floor. So anybody who has questions, please type them in the chat, and we will, ask Cody our questions. Actually, one question first, starting off. Is it possible to send these patient education resources to us? Meaning AHAC. So, and I guess any other, people who are here, if they're interested, having these resources, that you shared, that you provided to these providers and to the patients. If there's anybody else, who's interested in having them for their organization, would you be willing to share those with us? Because those are really great resources.
Yeah, the great thing about most of the resources we use were they were already created. We weren't trying to recreate the wheel here. The Word documents, anything that I showed there is stuff that I created, and I could share that. But as far as educational resources, we use CDC or the 6 building blocks of Washington University, which did a similar research project, and that's where we got a lot of our materials from.
Okay.
So if you need me to share anything, I can send you links to those websites, and they'll have all the educational materials there.
Okay, that would be great. Yeah, and that goes for anybody here. I know a lot of us here are providers and work in a lot of different healthcare settings. So if anybody's interested, please reach out. We'd love to share those. Um, I have another question here. How did it go for provider buy-in to try this at the Hurdle Elmwood Clinic? So when you guys initially wanted to introduce this research project, how did it go working with the physicians and nurses?
So like I said, I worked with Dr. Diaz Del Carpio. He's MD, MPH, and he was an attending at the clinic. So um, as far as residents, they didn't really have a choice to buy in. But other attendings, they seemed like it was a good idea. They seemed to like the idea. And as well, also as the patients really liked the idea as well. We had many patients say, why haven't you been doing this like for a longer time? It just seems like a good idea to have this appointment that we can focus solely on pain, because it's such a big issue in my life. It's something that happens every day. So I think providers and patients, residents, they all seem to take it pretty easily.
Awesome. Okay, I have another question here. How does implicit bias play a role in pain treatment?
That is a great question. So there's plenty of research coming like that's out that says minorities, specifically African Americans, are less likely to get pain treatment because of biases implicit biases that we have. Physicians are less likely to believe that minorities, specifically African Americans, are less likely to be in the pain that they say they are. So it makes it more difficult to treat pain. And I think appointments like this, where someone's coming in specifically for pain, no other chronic conditions are on someone's mind, just for pain. We're using the PEG to quantify pain. It really helps to address not necessarily implicit bias, because there's always going to be those implicit biases, but it helps to put a more emphasis on treating pain, especially for minorities.
Okay, thank you. Another question here. What is the percentage of HIV-1 and opiate use comorbidity that you see in Western New York? I don't know if you can, attest to this.
Yeah, I do not have data on that. I know that if you're more likely to have like HIV, obviously if you're using IV drugs, but you're more likely to contract HIV. But I do not have that data.
Okay, yeah, no problem. Thank you. Um, Yeah, there was another question too, in regards to pain management, because obviously this whole project was based in pain management and opioid prescriptions. Were there any more chronic pain like diseases or symptoms that you guys noticed more common within the clinic, that, you know, there were certain patients with this disease or this, you know, whatever, that they were more highly prescribed opioid prescriptions?
Um, Not necessarily, and the data is not available yet. We do have a section of our data where we are collecting um, their main reason for getting prescribed opioids. So we'll see eventually. But as far as like a major disease, I mean, people with it's very widespread. It goes all the way from diabetic neuropathy to like chronic back pain. It's very widespread. Pain and opioids have been used for most chronic pain in the clinic and the clinics around the U.S. As far as I was also thinking about the implicit bias question, I think that's a good thing to bring up. So we are going to create educational sessions for these providers at the clinic and hopefully spread them into other clinics, as the idea is to try to implement once we get this research running again and we can find out if it's successful or not, or if we have to tinker it and maybe um, improve it. Hopefully we can implement it in other primary care settings, BGH, ECMC, and I think we also are including educational sessions, and I think that implicit bias should be something that we focus on in those educational sessions, seeing as it is such a big issue with pain.
Okay. I have another couple questions that just came in. One, if a patient was weary of using opioids due to the negative side effects and possibly addiction, what are some alternative medications or therapies that you could offer to them?
It really depends on the type of pain. So we gave providers in our clinic a breakdown of different or common types of pain and pain areas and what other non-pharmacological approaches you can take. So let's say someone has nerve pain, a nerve blocker like gabapentin can be helpful, and you can use it in patients that have comorbidity such as anxiety or depression. Um, and also like things like back pain um, are more successfully treated with physical therapy and exercises. The only issue with that is you have to have the ability to pay for it or insurance. So it really depends on what type of pain, and it's difficult to say depending on what type of pain you have. You have to address it individually with each patient.
Okay, thank you. Another question. To discuss implicit bias for minorities, how would the PEG be successful in determining the pain one has if doctors already have a preconceived idea about their pain level? And how do you think we can eliminate these biases?
Yeah, that's a great question. And yeah, so I guess if you have implicit bias, which is common, and you have preconceived notions, the PEG may not be as successful. It's just a way to quantify. It's so difficult to treat pain, and the way that we use the PEG is not. We're not comparing you to another person. What we're doing is what's your acceptable pain level? So do you want to get down to a 4, a 5? Are you at a 10 right now and you want to get down to a 5? Is that your acceptable pain level? You come in for the next appointment. Are you at a 5 in these treatments? No, you're still at a 6. We're going to try to adjust. It's a way to, it's not, okay, so you're at a 5 and someone else at a 5 and they can tolerate a 5. So you should be able to tolerate a 5. It's, it's all patient oriented. It's all the PEG is used to quantify their pain through their perceptions. So it's not something that we're using to quantify compared to other people. It's just a metric we use to help. And that's somewhat addresses implicit bias. Um, because doctors have to understand, and this is another thing we have to do is through education, like I mentioned, we should address implicit bias. Um, Understand that people can tolerate different levels of pain, and someone's 7 could be someone else's 2. So we have to understand that we're using the PEG, not comparing it to other people. We're using it to quantify someone's pain and help them address it, get to the acceptable level that they want.
Okay, thank you. Another question, is the stigma of fibromyalgia patients decreasing in these clinics? Are they subjectively treating this disorder, especially in young people?
Um, it's also something I can't necessarily speak of. Um, Again, I wasn't looking specifically at certain diagnoses. I'm looking at the data as a whole, for opioid patients or patients on long-term opioid treatment. So I'm sure it's a great question. I can't speak on it.
Okay, yeah. No, I do know that they are, trying to, like you kind of said before, that they're trying to look at alternative treatments. But, I appreciate, that, I understand that wasn't the objective of the research. So one last question here, and then we'll, kind of wrap it up. How do you think that the patient education in regards to, the opioid, prescription pamphlets that you gave them, how do you think that benefited or impacted mental health for the patients?
Um, the education, I'm
Or just
not.
the pain management sessions in general?
Oh, okay. Well, there's some aspects of pain management that mental health are involved in. So, I mean, people who show symptoms of depression may perceive their pain as being more. So there is room to address like pain with mental health. I don't know if that's exactly answers your question, but like I said, that previously, there's medications that can address mental health as well as pain. But I think, um, sorry, I was reading out the question.
That's
Um, it's,
okay.
it's a difficult question to answer, especially since we haven't had many of the patients fill out the survey yet. And maybe that's a question we should look to address, because I'm sure if your pain is bad, your mental health is like it can affect your mental health and vice versa. So that's be something we can look to address.
Okay. Yeah. And then last question here. Wondering if there was any strategies to reduce doctor shopping.
Yeah, so the iStop was ideally created to prevent doctor shopping, but I know that doctors can still override it, and sometimes people get prescriptions earlier than needed. The idea is we we're handling a lot of matters internally, so like if someone goes to another clinic and asks for a prescription, that's not something we necessarily are tracking, but the the education aspect is and even substance use disorders or um, diagnoses or urine toxicology screening is helping to address underlying maybe misuse, and getting people into treatment earlier, um, before it gets to the point where they're doctor shopping or using illicit drugs. So that's the main method I would say we're reducing it, is kind of getting people into treatment if we recognize misuse. Um, and using iStop. But other than that, I don't know how we would know necessarily. But yeah, iStop is the main way, I would say.
Okay. Awesome. Well, it's 101 here, so not to take up anybody else's time and your time. I would just like to say thank you so much for such a great presentation. That was extremely educational and really informative. So thank you so much, Cody, for that presentation. And thank you all so much for attending as well. We really appreciate all of your support and coming to this educational series. Next week we have Shauna Pratt from Evergreen Health. Yes. Yeah, sorry. So they will be presenting next week, same time, Wednesday at 12 o'clock. So please attend if you are interested. But other than that, thank you all so much for attending. Thank you, Cody, for this presentation. And I hope you all enjoy the rest of your day. Thank you all so much.
Thanks, guys.
Thank you, Cody.